Good morning, everyone. Thanks for joining us. My name is Bob Brocker, and I want to introduce Barbara Boyer, who's our Executive Director. And we are with AgeWise Colorado. And you joined the 40th webinar that we've done since we launched in the summer of 2021. So we're happy to be hosting this one today. It is going to cover how UC Health is using AI to improve your healthcare. And I have just a few slides, and then we'll turn it over to John, who is going to be moderating the panel today. So today's presenters are John Ingold, who's the healthcare reporter for the Colorado Sun, and then our panel, C.T. Lin, MD, who's a professor of internal medicine at UC Health, Matthew DeCamp, also an MD and associate professor at UC Health, and Casey Green, PhD, director of the new Center for Artificial Intelligence at UC Health. So AgeWise Colorado, we're all about serving aging Coloradans and the caregivers of today and tomorrow. Our mission is to connect at no cost to the user, all older Coloradans and their families, to reliable, helpful services and products, information, assistance, and education, as we're doing today, to help the over 3 million people over the age of 40 in Colorado on the aging journey to age well and age wisely. And it's illustrated here below in this little graphic. And then finally, this is just a screenshot from our website that shows, here's where you go to explore the AgeWise Colorado
webinar with AgeWise on AI and medicine.
Okay, so I'm going to stop sharing now and turn this over to John. John, take it away, please.
Yeah, thanks, Bob. And I really appreciate you and AgeWise Colorado giving us the chance to put on this panel. So as Bob said, I'm the healthcare reporter for the Colorado Sun. And if you haven't heard of us, we're a statewide, independent, nonpartisan news organization that's about 5 years old, a little more than 5 years old. And we cover topics that are just like this one, sort of these really detailed, in-depth policy issues that really affect and impact people's lives. So this panel is one that we first did at a Sun event called SunFest back in September. And I was telling our panelists yesterday that it was one of my professional highlights of the year. It was so much fun, so interesting. All our panelists are just really, really knowledgeable and very thoughtful on this, and they all come at it with their own expertise. So I think you're really going to enjoy what you're hearing today and walk away with maybe some perspectives changed or maybe not, but at least more information when you go out there in the world. So I did want to introduce our panelists a little bit more. So we mentioned Dr. Casey Green. So Casey, in addition to being the director of the Center for Health Artificial Intelligence at CU Anschutz, is also a professor in the School of Medicine. He runs his own research lab. He is really one of the national experts when it comes to using data and data systems to try to both study human health and improve healthcare. Dr. C.T. Lin was mentioned as the Chief Medical Information Officer, which means he is in charge of, among many other things, all of UC Health's efforts to try to use these data analytics tools, including artificial intelligence, to improve healthcare throughout the UC Health system. And Dr. Matthew DeCamp is a bioethicist at the Center for Bioethics and Humanities. And in this work, he has really studied a lot of ethical questions as it relates to artificial intelligence, patient trust, bias, and all these really important things that we're going to talk about today. So to start off, I thought I would start with Casey. I think we hear a lot about artificial intelligence these days, and everybody seems to be claiming to be using it or to have their own tool, but sometimes it's important to set some parameters for what exactly we're talking about when we're talking about artificial intelligence. So Casey, why don't you define it a little bit here for our purposes, and also talk a little bit about where it's drawing its information from.
Yeah, so there's a lot of different definitions of artificial intelligence. I think the the types of artificial intelligence that folks are usually talking about fit into kind of two groups. So one type is sort of rule-based or automated reasoning systems. So these are attempts to take a bunch of facts and information and put them into a system where they can be used to kind of generate additional potential statements. And then the other path is machine learning systems. So these are systems that we attempt to essentially put a lot of data into and then have those systems make a prediction. Rule-based sort of systems or others kind of based on semantic reasoning were generally quite popular in the past. That's given way over the last 10 or 15 years to an enormous amount of enthusiasm in these machine learning based systems, both of which generally fall under the umbrella of artificial intelligence. Today, when people talk to me, they mean the machine learning based system. That is what people always are talking about when they talk about artificial intelligence. So for the purposes of this, I think that's where we'll focus. If you've heard of ChatGPT or you've heard of any of these other kind of AI systems that are easy to access, these are all machine learning based systems. John, you kind of asked like how they work, I guess, is a fundamental. Yeah. So because these are all falling into the machine learning camp, they work because we feed them a lot of data and we tell them a little bit about what we'd like to see back. And then we essentially are training a computer to be able to produce more of the stuff we think we want to see. And so, one example of this type of system is ChatGPT. So ChatGPT is a system produced by a company called OpenAI about 1 year and 5 days ago that went live. And the way that model is trained is by taking an enormous amount of text. So text from books, text from internet forums, kind of all over, text from newspapers, taking it, cutting it off at a point, and then training a computer to predict what comes next. And then once you do this a little bit, you have a model that can generate text that looks like it could have been written by a person. And then the next part of the model is essentially having people say, okay, I like the output that this produced. I didn't like the output that produced. And using that to kind of refine the types of outputs it creates. And at the end of the day, what it can actually create are sentences or questions. I mean, I fed the panel topic here into ChatGPT right before we started and asked it to generate some questions that could come from the audience. And one of the questions that it generated is, how can AI improve patient outcomes and the overall quality of healthcare services? So it can produce things that are very relevant to the topic at hand with a little bit of information.
Mm-hmm. And I was curious what your prompt was when you fed that in, because one of the things that's important is it's not just what resources the AI is drawing from, but also what exactly you're asking it to do, right?
Yeah, so I gave it a description of our panel, and I asked it what questions should be asked, and it came up with a bunch of questions that were kind of less pointed than that one. And so I asked it, well, actually, can you guess what some audience questions are? And so this was one of its guesses for an audience question. And that prompt actually seemed to give me stuff that worked. But I agree, John, that's a great point. It's like, it's not just about the model. It's also, because of the way these models work, some prompts will produce very useful outputs. Other prompts will produce outputs that are generally useless. And the difference between a useful and a useless prompt are, can be like 2 or 3 words. There's an interesting study where people tried putting the word please in front of their prompt. And if you put please in front of the prompt, often the outputs appeared improved. So that's kind of interesting. And I imagine that's because in human text, right? If someone says, please this, and then there's text that follows, the text that follows the please is more helpful. So maybe these things will teach us manners. Yeah.
It's nice to be nice.
Yeah.
I have to say, these questions are making me feel competitive. I feel like I need to beat the AI in coming up with better questions. So one thing I did want to ask is that people have probably heard about black box algorithms. This idea that, you put your question in and it kind of gets jumbled around and then an answer gets spit out and you can't necessarily understand what happened there. And I was wondering if you could explain how those work and why those exist.
Yeah, so the algorithms that people are using, like ChatGPT, for example, and these large language models are at this point still essentially black box algorithms. So they can have billions of parameters, which means they can have like billions of different numbers that are all kind of pieced together to produce the output. And what it really means is we don't really know how what we put in relates to what we got out. I would say that the models that I hear people more excited about in healthcare are not always these black box algorithms, but algorithms where we can draw a connection between this was the input, this is the output, and we have an understanding of how this input got us to that output. Especially if folks are trying to build predictive analytics in a healthcare setting, it's really very important to understand how those models work so we can understand where they can be used effectively and where they can't, where they would struggle. And I know we'll get to CT, but I wouldn't say any more on this topic because CT is the world's leading expert on how to get these things to the point of care so they help people.
Yeah, well, CT, why don't we turn to you? You're actually doing it right now. You're implementing these things with UC Health. So maybe you could talk about what you have in place and how it's going.
Thanks, John. I thought I would separate my remarks into two categories. One is AI that has matured in its use at UC Health, and then generative AI, which is the brand new shiny object that everyone's thinking about, the ChatGPTs of the world. So with your permission, I'm going to put off ChatGPT for just a minute because I think there's some really interesting things going on there. But what I do want to point out is using our AI tools at present and the potholes we've stepped in and the failures we've had on our journey, which I think is instructive and hopefully will generate some questions in regards to how we go forward. Our biggest and longest lasting machine learning / AI predictive model that we've had in place is the sepsis predictive model. And so let me explain that a little bit. Sepsis is a blood infection that's a very serious infection that by the time you acquire it, whether in hospital or out of hospital, the mortality risk is 50%. It's very difficult to treat. It's basically an infection of the bloodstream that by the time it gets to this degree of severity, you can throw everything you have at it, fluids, antibiotics, maximum mechanical support, whatever we have, and yet we still have about a 50% success rate. And essentially a 50% failure rate because of the severity of this infection. And the idea is that the early symptoms and signs of sepsis are very difficult to tease out. Blood pressure changes a little bit, heart rate changes a little bit, but then in the hospital, you're taking care of 400, 1,000 patients, and everyone's heart rate is a little bit off. Everyone's blood pressure, respiratory rate is a little bit off. Everyone's temperature, fever curve is a little bit off. And where can you find signal to figure out how to intervene earlier? And our big idea a couple of years ago was to say, well, we've got years of data on, millions of patients. Why don't we feed all that data into the predictive algorithm, into an AI machine learning tool, and maybe it'll spit out a way of monitoring or looking at the patterns in the data that humans couldn't possibly, spend that type of time and really try to integrate that together. And we did that. So we built a model where part of it came from our electronic health record vendor, Epic, and part of it were some of our researchers on our own campus developed some of these models. So we sort of combined these models together, and we were very happy to be able to come up with a model that was able to be on the order of 95, 98% sensitive, and then 85% specific. And you think these numbers are pretty good. You would think that this works out quite well. And so we started to put them into the electronic health record in front of nurses and doctors taking care of patients. And we thought, like the movie says, if you build it, they will come, the Field of Dreams movie. And we were patting ourselves on our backs about like, well, look what we did. We did this great math and we put it in front of the clinicians who are taking care of patients. What could go wrong? This will be terrific. We'll be able to save a lot more lives because we can intervene earlier because the predictive model is helping us. And the downside of what we did, though, in hindsight, and the reason that we failed in our version 1 was because this tool was so sensitive, right? The nice thing is it's sensitive at 98%. The direction from our leadership was we can't miss any cases. Whatever math you do, you need to make it super sensitive so it picks up everything. And in hindsight, when we do the analysis for what happened the next 3 months, was it did pick up every case of sepsis. And it picked it up 8 to 12 hours earlier than doctors would have picked it up. And that's great. But the downside is, as a consequence, it made alerts on a bunch of other patients as well. So if an algorithm is sensitive, it's not necessarily going to be very specific. And so the downside is there's a ton of false positives that come with it. Well, sure, for every true positive, there are potentially 25 to 30 false positives. So if you can imagine, if you put yourself in the mindset of a clinician walking around the hospital taking care of your patients, the first potentially 29 alerts you get, this patient might have sepsis, and you go figure it out, and you go, no, actually, no, this patient doesn't have sepsis. Do that 29 times, or maybe the 30th time the algorithm is truly showing you a patient with sepsis. How long is a clinician going to walk around and go, sure, I'm willing to tolerate that this thing is wrong 29 times out of 30. And so what happened was we actually had no change in behavior. Clinicians basically start to blow off these alerts. This is not helpful to me. I get a ton of alerts. It doesn't really help me. And what we ended up having to do was put a virtual health center team together, where that's all they do. They have no other responsibility except to look at these alerts and then chew through the chart and go, nope, that's true. That one's false positive. And by being able to have a dedicated team that has no other responsibilities, then by the time the virtual health center calls the bedside nurse or doctor, and they can say, I think this is a real one, start the fluids, get the antibiotics going. That was when we became successful. But it took us taking apart our teams and reassembling them around the algorithm or the tool. It's not just where you can just flip a switch and go, good luck, it's going to work great. You have to figure out how it works in the context of busy doctors and nurses running around the hospital. They have full-time jobs already. This is another essentially full-time job. And for us to be able to take the team apart, put it back together in a special way, finally did allow us to make changes. And in the first year, we saved 200 more lives per year from sepsis. And in the most recent year, we've saved about 800 more lives per year from sepsis as a result of these early warning systems. But it took a ton of non-mathematical work to get these tools to actually function well.
Mm-hmm. And that was really fascinating to me, because if you look nationwide at news stories about these sepsis prediction tools, or you read some of the studies, what's out there is not very encouraging. It's not very enthusiastic about their effectiveness. And what you seem to have sort of demonstrated is that it's not necessarily just the tool. You can't just create the tool and walk away. That there still needs to be kind of that human intelligence aspect of how you use the tool and how you think about how your own personnel systems work to implement that tool.
Absolutely right. I've read those stories as well. I think around the country, there are many health systems like ourselves going, oh, shiny new object, that's great. Turn the switch on, show it to the doctors
Mm-hmm.
at the bedside. And there's an under recognition that these, just because you have a new tool doesn't mean that it automatically is useful out of the gate. You really have to reconsider the way you do business, to reconsider what roles you have. And we actually had to repurpose entire jobs to be able to work with the AI in an effective way.
Mm-hmm. Now, you also have created some tools that are hoping to save on workload stress for physicians and other medical providers, and maybe you could talk about those.
Yeah, so I'll switch over to more of, again, this is the shiny object, the generative AI tools. We're doing this in 2 or 3 areas. One is what's called chart summarization, and that's just getting off the ground, where we can apply the AI to say, as a clinician, as you might imagine, as we generate tons more data on patients, there's a lot more to read. So if you're a clinician, let's say I'm an infectious disease specialist, and I'm asked to consult on a new patient. This patient has 10 years of data. There's potentially 1,000 progress notes written by other doctors, and potentially 10,000 test results over the last 10 years that someone would have to go look through. And you could imagine that would take hours of reading and assembling. And our anticipation is, could it be that an AI could read the corpus of this patient's electronic record and say, in summary, we think that this person has had these 3 or 4 infections, and this was the outcome. These are the successful treatments. These are the unsuccessful treatments. This is the pattern of care for this patient. This would be a wonderful time-saving tool. But then the question is, as you know, with some of these tools, the risk of hallucination and the AI, we haven't talked about the term hallucination, but the AI is just following directions from you. If you say, please summarize, but it might have low confidence in some of its summarization, but it knows you're looking for it to give you a summary. Sometimes it makes things up because it sounds plausible in its training data. So we still have a lot of ways to go to get to a point where we can have confidence that when a tool is doing summarization. So that's one project that we're working on. That's in the early stage. But something that we're actually deploying now in 3 out of our clinics is the idea that an AI could take an incoming patient's message and generate a draft reply for the clinician to use. So if you can imagine that over the past decade, as we've allowed patients to send messages through the patient portal to their doctor or nurse, that during the pandemic, that volume exploded. For us at UC Health, we have about 4,000 doctors, and the volume of incoming patient advice requests went from our baseline in 2020 of 53,000 incoming messages per month. It ballooned to 190,000 messages per month. The average primary care doctor gets between 30 and 40 messages a day. And at the end of a clinic day where they've been treating 18 to 20 patients, then they go home and there's evening work, what we call pajama time for our clinicians, where they're answering these messages. And it can be a big source of burnout for our clinicians, that really, that you're never off the clock. And what we've tried to do is use the AI to say, well, in some fraction of these cases, the AI can generate an entirely workable reply to the patient with very little effort on the clinician side. For example, if a patient says, I hurt my ankle, and what do you recommend to do? The AI, based on training data from the internet, can very easily say rest, ice, compression, elevation. In fact, it's very nice at saying that. It'll actually reply to the patient, I'm really sorry to hear that your ankle is hurt. That really should be, that it sounds like that's really affecting, how you're able to get around. I have some advice for you. Consider resting it more, use ice and compression, and this is how you do that, and then elevate so to decrease the swelling. Sincerely, Dr. Lin. And you can imagine a clinician going, that's perfect, send. Other times it doesn't work very well when the incoming message is, hey, my last CAT scan was really hard to understand. Can you give me some advice on what it means and what I'm supposed to do next? And the AI is not really very good at reading scans. And in fact, we're having a hard time getting these things to connect in a way that is effective for the AI. And so the AI ends up saying things like, it's important for you to talk to your healthcare provider because these things can be very difficult to comprehend. And you go, well, I can't use that reply at all. I'm going to have to write my own. And so we have mixed results, but it's very interesting that our first passes at this, we're getting about 15 to 20% of the incoming messages the AI can generate a useful reply that the clinician, who's always in the loop. There's no, don't get me wrong, there's no automated reply from the AI. The AI's draft is always put in front of the clinician, and the clinician can then judge, I can use part of this, I can use all of this, I want to use none of it, and then generate the reply back to the patient. Yeah. So I'll pause, and I know that Dr. DeCamp's actually been one of our pilot clinicians in the clinics doing this, and would love his reaction to that.
Yeah, absolutely. So I should have mentioned that both CT and Matt are also practicing physicians. And Matt has been using the AI email response tool. So Matt, why don't you tell us a little bit about that, and then let's talk about some ethical issues.
Yeah, sure. Thanks for organizing this panel. And I think, like CT said, my experience with using the portal responses is that sometimes they're very helpful and sometimes they're not. Sometimes it requires more editing. Sometimes the responses are actually humorous and enjoyable to read before I correct them and send them to a patient. I think one of to connect this to ethics very quickly, I would say that one of the reasons why this matters from the standpoint of ethics is that in at least American medical ethics and medical ethics generally, the patient-clinician relationship, that therapeutic relationship, is really important. It's foundational to a lot of medical ethics and to how we think about ethics. And when tools like this enter the clinic, the interesting thing that we see from other areas of research is that this tool doesn't affect the patient's perception of just the tool, but this tool can also affect the patient's perception of the clinician or of the health system where the clinician works. In a setting where we know that trust in clinicians and trust in health systems is both really important for achieving good outcomes and also in some groups and communities quite tenuous. And so what does this mean for ethics? Well, it means things like thinking through questions about, well, how do we make sure that patients and clinicians really understand where this content came from? You know, that this content was computer generated. That's not always easy to communicate. How do we make sure that the content isn't biased in certain ways because it's built on data sources from history, and history has biases, and some of these biases can end up infecting, so to speak, the content and resulting in biased content to certain patients. And so that, you know, that to me connects the patient portal messaging to some core issues. And maybe just to add one more, you know, we all know that AI influences choices. Anyone who's used a recommender system on Netflix or YouTube, where 80% of choices are thought to be algorithmically influenced. We think about that when it comes to AI in healthcare, because many of us think of healthcare as being a little bit different than the Netflix recommender system. And so the way we influence choices and the way that AI could help influence choices for better or worse, by the way, it doesn't have to always be for worse, it could be for better. We really have to think about what counts as an appropriate influence, how much influence, and how do we filter out when influence can become more sinister things like manipulation.
Yeah, so I wanted to ask about that that issue of patients knowing that they're dealing with an AI. And we should mention, if we didn't, that the AI generated responses that come to patient emails to you, they will say at the bottom, like, you know, drafted by an AI, right?
That's right. That's right.
But there's an issue of whether patients read that or notice that. And we were mentioning or talking right before this started about some research that you and your colleagues have worked on, looking at an AI chatbot and whether patients knew they were dealing with an AI system there. So maybe you could talk about that.
Sure. So one of the things we were talking about is that across many industries, and I think in this case, healthcare is no exception, there are studies suggesting that 30% of people who interact with an online conversational agent or chatbot don't actually know that this is an unsupervised computer. You know, they mistakenly think that there's actually a person on the other side typing, or at least a person supervising the typing. And so we've seen this phenomenon in other areas. Again, I think most people believe that healthcare is different. We should have higher standards for what people understand and how informed they are about what's really on the other end of the computer intersecting with them. So yes, in our messages, there is this statement about being generated by a computer and edited by a clinician. But the real world ethics question always becomes, well, how do patients understand that? Do they read it? If you ask them after the fact, do they remember that it was generated partly by a computer? And the reason why all that is important is, again, because these tools don't just affect the patient's perception of the tool, they affect the patient's perception of their clinician and of the health system that's using the tool. So it's great that we have disclosures that inform people, but it's, you know, you think about the terms and conditions that we all agree to and hardly read in the rest of our life. You know, we have to make sure that when we do this in healthcare, that we really understand that people know what they're dealing with.
Yeah.
Matt, can you speak to whether patients have actually commented on that in your experience?
I have not had a patient comment on the disclosure itself. And I don't know if that's come up in some of the evaluations that we've done or that I know you've spearheaded, but I've not heard a patient mention it, no.
A couple of observations, John, that we've had a couple of people out of our 3 clinics. We have about 40 or 50 doctors using this tool in our pilot environment. And we've had several physicians comment to us, hey, my patients actually like that we're disclosing to them that there's automatic generation. In fact, one of them said, I appreciate that, UC Health is investing in something to reduce the burden on my doctor because I know you work late into the night for me. And so there's actually some interesting sort of positive feedback that we've had from that disclosure. We're aware that some other health systems doing the same thing from our Epic electronic health vendor have chosen not to have a disclosure statement. So this is within the purview of each health system to decide whether to put a disclosure statement. And I'll just throw one other curveball at you, which is, this is an early comment from one of our other clinicians who's doing the study with us, is that we're finding that some clinicians are removing the statement. And that's a whole other ethical sort of concern. Like the health system automatically puts a statement in there, and there's certain individual clinicians going, no, I don't want to have the patient know that I had help writing this. So there's all kinds of curveballs that are coming out of this experiment.
Yeah, maybe just to comment on that quickly too is again at the bigger picture ethics level. We do algorithmic stuff all the time that we don't necessarily tell patients about. And so while we might knee-jerk react, and I agree, by the way, with this disclosure statement, there is a separate question of we don't always disclose everything in every instance. And so ethics is really about drawing the line about, well, when do we need to disclose this and not that? And how much do we disclose and how do we disclose it? That's where I think the ethics is really interesting. It's too easy to suggest that we could literally disclose everything to everyone all the time because it came from an algorithm, including, by the way, algorithms inside the clinician's own head that are being used to make decisions, which are, to Casey's point, black boxes many times.
But at least you can ask the clinician how they came to that decision.
I would just say, I did not say that. That's you.
CT, I don't mean to put you on the spot here, but you've mentioned Epic a couple of times. Epic is a provider of electronic medical records. So it's how you keep track of patients' health and what's going on there. Do patients, when they sign up for their portal accounts through Epic or with UC Health, do they sign some sort of acknowledgement that this health information that is being provided to Epic is going to be used by AI? Because there is that aspect of, AI needs data to function. In health, it needs people's health data to function. Do people have the ability to consent to that? Or what are the consent aspects of that?
It's a good question. I have not recently gone back to revisit our consent form. We have a consent to treat that patients sign every year. And I agree that probably most patients don't read through the 7 pages of fine print of how we share that information and what it's used for. We certainly don't tell patients, hey, by the way, every patient who comes to the hospital, we're feeding this into the sepsis algorithm to try to keep you safe from sepsis. I mean, can you imagine a 100-page document for consent to treat that says every place that we've ever used a predictive algorithm, we're going to disclose to you in case that a condition comes up in the future during your hospitalization? We don't do so. And how can you reasonably do so because it's embedded in many of our tools? And at what point does an expected predictive algorithm be part of when I come to you, I expect that you have all these protections in place because that's standard of care. In fact, I want you to tell me when you're not using an algorithm, to keep me safe. This is a very sticky spot. I don't think it's very easy to be able to do that effectively.
And CT, we're getting some questions in the chat, which, by the way, folks, if you have questions, go ahead and post them in the chat and we'll get them answered. But we're getting some questions, just some basic questions about Epic, how they work. They're the largest health medical record provider, electronic medical record provider in the country. Is that right?
Yes, they are.
And they have been developing.
Let me answer this particular question. Do patients even know their information sent to Epic? Let's be careful about sent to Epic, because maybe a point of clarification so that people can understand this. Every health system that uses the Epic electronic health record, I think Epic claims that something like 65 to 70% of all US adults have information in an Epic chart. That is hosted by the particular health system. So UC Health has an instance of Epic, and the data for these patients is hosted at UC Health. Mayo Clinic has their own. Cleveland Clinic has their own. UC Davis in California has their own. There is a subset of this data that is de-identified and then aggregated by Epic for sort of international cooperation for research collaboratives. So that's something that is in the consent form, that information for treatment, payment, and operations. This is a HIPAA condition from 2006 that patients' data can be used for operations. And when this data is aggregated, mostly in a de-identified way, then researchers and clinicians can say, as we try to improve treatment for, let's say, asthma, we know that 50 million patients have asthma, and we can do research on and then try to apply improvements to the care of asthma patients and then send that finding back to the health system and try to improve their care. So the most part, data is aggregated and held at the health system level and is not, quote, sent to Epic. It's not sold, it's not transmitted, it's not given for free. It is held in a very specific way that's controlled by HIPAA, which is very tightly controlled in terms of what it can and cannot be used for. So there are protections in place, and the federal government is pretty good at enforcing that.
Casey, I wanted to ask you one question. CT mentioned earlier about the potential for hallucination by your AI systems. And just to kind of put a fine point on that, if that happened in healthcare when the AI was doing a chart summary, that could be pretty catastrophic. I don't know if people saw a news article recently this week where there was a lawyer who was trying to find cases, past precedent cases, to support his legal argument, and he asked an AI system to come, give me some of these cases, and the AI created fake cases that he then submitted to the court, which is obviously embarrassing, and he ended up being sanctioned. But if that happened in healthcare, it could hallucinate that somebody had, cancer when they didn't have cancer, or that they received some medicine when they didn't actually receive that medicine. So why do AI systems sometimes hallucinate, and how do you prevent them from doing that?
Yeah, so part of the current systems, these large language models that are used that have this tendency to do what's called hallucination, the reason that happens is because the models they're trained to generate text that sort of, completes a sentence and that people would like to see. And in general, people would like to see kind of accurate information, but sometimes, inaccurate information fits the bill. There was an older class of methods, the sort of semantic and rule-based reasoning methods that didn't have this type of issue, but sort of had other issues with their ability to generalize to new settings. I think in the long term, we are going to start to see more of a hybridization between these methods so that we can potentially get the ability to generate text while being grounded in, agreed upon reality. But I can give you an example of how we've seen this in some of our own work. So there was a postdoc in the group who saw large language models as a path to better writing of scientific manuscripts. If you write a scientific manuscript, there's all these esoteric rules, like this section needs to be written in that tense, this section needs to be written in this particular way. And so one of the postdocs in the group came up with a way to use a large language model to sort of tune the text in these ways. And that had some benefits and some drawbacks. So one of the things that the model actually identified was that there was an error in mathematical notation in one of the paragraphs. And it fixed the error in mathematical notation in one of the paragraphs that the postdoc didn't notice when he wrote the paper. I didn't notice when I edited the paper. And the peer reviewers didn't notice when they reviewed the paper, because this paper had made its way almost to the final, like it had made it through peer review and was at the kind of proof stage when we ran this on it. We're like, okay, so it noticed that. And that was very exciting. Another thing that it did was it added a sentence to a paper that said we did something. We didn't do that thing. It would have been a good thing to do, like it's like the next step in the project, but we didn't do it. And so, I think when they hallucinate, we sort of sometimes will hallucinate things that are kind of plausible or the next step. So yeah, I agree with your concern that there is some risk here. I also think that it is important to recognize that electronic health records are not, even in their best state, are not always an accurate representation of what happened to a patient. So you said, like, what if it imagined that a patient sort of was given took a specific medication or didn't take a medication that they did take. What's in the electronic health records is potentially like what's prescribed, but we don't always know that a patient filled that medication. We don't know that they, took it on schedule every single day. So I guess I would also say, like, yes, I see that hazard and I see that risk. And I think it's incredibly important for when these systems are deployed, that they're deployed in the way that UC Health is thinking about, sort of with, humans in the loop to understand the practical implications and to vet the information. But I also would caution us about over-interpreting the exact fidelity of the electronic health record as a way to describe what happened exactly to a patient.
Yeah, maybe ethically, one, as you were speaking, Casey, I thought from the standpoint of ethics, the situation you just described does bring up interesting issues, I think, around moral or ethical responsibility for decision making, though, because we probably think differently about an error deep in the medical record made by a person that someone reads and an error that could be generated by an AI that hallucinates, or any of the other multiple ways that errors could occur or be propagated in records. And there are questions people are asking about, well, who's responsible for an AI-based decision? Is it the developer? Is it the health system that chooses to use it? Is it the clinician at the point of care who doesn't override it? And that's another aspect of ethics that I think is really active here.
CT, when you're thinking about developing some of these new systems, how do you end up shaping the safeguards that go around them? How do you think about, okay, here's the extent that we need to test this and verify this? Because obviously an AI system that is in charge of summarizing patient progress notes and somebody's entire medical history, that then needs to be checked in detail all the way back through those notes, isn't actually saving anybody time, right?
I think we have a big hill to climb in order to properly or effectively deploy basically a new entity in our healthcare thinking. Up to, we work in teams. As a physician, I have, well, not me personally, but many of my colleagues have a physician assistant or a nurse practitioner. Many of us have nurses and medical assistants we work with. We have front desk clerks and a number of other staff members, and we work effectively in teams. And what we've done is we've introduced a powerful new entity right in the middle of our team, which is this AI. And how do we work with it? And can we trust it? And is it hallucinating? Is it just that it's faster, but the trade-off for being faster is that, what directions is it taking us? And maybe in some cases it's making better care for us, like with the sepsis algorithm. But as we climb the ladder of like trusting it and then giving more responsibility to it and having it play a bigger role in our teams, I think we have to go back and question every step of the way. Even with our mature product, with the sepsis algorithm, that we're very happy that it's saved, 200 to 800 more lives per year because we're faster at detecting sepsis. You can also ask the question, CT, how can you prove that it's not biased? How can you prove that maybe that African-American patients get the same level of sepsis detection that Caucasian patients do, or Asian patients? Can you tell that it's differential, or are female patients less likely to be detected than male patients? Or is there some other demographic that we're not being careful about because this is the way it's always been? The AI is replicating and making that faster based on hindsight data, but was the hindsight data biased? How do you know that? And I'm going to tell you, I don't know. I'm very happy that it's performing and that we can show that it's saving more lives, but is it biased in some hidden way? And do we need to be more thoughtful about it? John, at every point in this process, you're going to ask me that question. I'm going to go, I'm very uncomfortable to tell you, I'm not really sure. That's another level of supervision that we need to think about. At the same time, if we take that to its logical extreme, we're aware that the FDA is looking at AI regulation and saying, we can't move too fast. And can you imagine us going back and telling the dozens of AI tools that we have in process to say, stop, let's submit everything to the FDA. And we know the federal government moves so effectively and so quickly that I'm sure they'll get us an answer back as to the way whether we can continue to use the AI as it is, or whether we have to meet a new standard. I think we could effectively bring innovation to a complete halt by saying, no, we have to be very careful. Set the standard for bias, set the standard for, unintended consequences, set the standard for XYZ, and all this supervision and adding additional committees to sort of govern this and ethical concerns. We could ramp that up so quickly that we could say, let's stop everything. And that would be our fear as well. So it's a tough balance to think about this.
Yeah. Matt, how do you view that? So obviously, what CT is describing is something that's thoughtful, that's methodical, and sometimes technological innovation doesn't necessarily move at that speed. It moves a little bit faster. So is there a risk that the technology sort of gets out ahead of some of these systems that CT is talking about? Maybe not at UC Health. I'm not trying to throw UC Health under the bus, but maybe somewhere out there in the healthcare world.
I think there is such a risk. I don't think it's actually unique to AI. It probably actually applies to just about any technology we've had in medicine. I like to give the example where there are a couple technologies that physicians were really strongly opposed to in the past: the stethoscope and the telephone. And so some of these concerns, we see concerns, and there's always the question of technology getting ahead. I think the role of ethics in many ways is to make sure that some of the concepts we've talked about today are at the table to help shape technology as it rolls out. I think bias is a great example of that. People in bioethics and medical ethicists are pointing things out like, bias is a data problem for sure, but bias is also a problem with the variables we choose to analyze. And it's a problem in the clinic where we know that clinicians, unfortunately, also exhibit biases and may use tools in biased ways. I use it for this patient and not that patient. And so bias is a really big problem, and it's a problem that goes beyond the data. And I think ethicists like to point that out. Ethicists also, I would say, have been calling for better reporting requirements for bias, pushing the FDA to consider bias standards in its evaluation of tools and so on. So I think at the end of the day, people like me who are interested in ethics and policy just want to make sure that these concepts are in the mix, sort of agnostic toward whether it has to be the FDA imposing them on people, on developers.
And I would just say, kind of jumping off of that a little bit, the closer that I get kind of from the AI world to the AI and healthcare world, the closer that I get to healthcare, the more people are talking about bias and sort of implementing these in ways that help patients, and less about this as kind of a pure computer science like path where they're not thinking about ethics and they're not thinking about sort of how this affects people at the point of care. So I think as our field is developing, I think it is not universally true, but I think it is broadly true that people recognize these issues and are working to use these new technologies to improve outcomes for all, not just for some.
There's a question in the chat that we got at the last panel as well, kind of this issue of, if you have somebody who has complex symptoms but no clear diagnosis, is there a future where there would be an AI system that you can just sort of plug these symptoms in and it would end up spitting you out an answer for what the person may have? Does that already exist? CT?
I'll jump in, and I would love my colleagues to weigh in as well. It doesn't need. I don't think you necessarily need to invoke a large language model or a generative AI to be already into the space of thinking about complicated or unknown diagnoses. For all the belly aching that my colleagues say about Dr. Google, right? Don't put your symptoms into Dr. Google. Who knows what you're going to get out? At the same time, I'm aware of a fair number of my colleagues who actually do use Google and say, I can't figure out this patient. I've had 10 years, 15 years of medical training, and yet this patient shows up. I have no idea. And you put these weird symptoms into Google, and it spits back a list of diagnoses that some of which the clinician goes, I didn't think about that. It's a good point. Let me go investigate that. So already there is some utility for a large search algorithm to, even without predictive analytics, predictive tools, generative tools, to be able to come up with something helpful. So already we're in this space where the technology can give you interesting insights even without generative. And now you add generative, and then look, where is that going to take us? This is a big growth area that I think we should be careful about. I do want to designate two different ways of thinking about generative AI and the assistance of technology. One is, I'm very fearful that we have patients going to ChatGPT, and going, hey, I have these symptoms, and what do you think? And it's spitting back a list of 10 things, and they go, oh my God, cancer's one of them, or oh my gosh, it looks like it's gout, and I better get this treatment, or I'm going to drink the cherry juice, or whatever I learned online about treatment. And then I go down that pathway where I have no native knowledge of this field, and I'm asking it to teach me something new. I'm very worried that AI is going to sound very plausible and very confident, and you're going to take that at face value. Mm-hmm. I think that's a huge risk. That, on the other hand, I think if you, as an expert, whether it's in medicine, whether it's in engineering, ask the AI to help you draft something, and you're the expert in that field, and it spits back something at you, and you can react to it with your expertise and go, that makes sense, that doesn't make sense. That's the sweet spot right now, where generative AI is faster than you, can think of things that you hadn't thought of, but it's within your expertise, and you can judge for yourself, that's nonsense, or that totally makes sense, and I should have thought of that, or thanks for writing that for me, because that would have taken me several hours, and you did that in a few seconds. I think that's the right place that generative AI has a role, but let's be very careful about saying it's going to spit back something very confident, and if you know nothing about that field, that right now, that's a terrible place to be using AI.
Mm-hmm. We had another question here about medical education, which is, CT, when we've talked before, you've mentioned AI being able to do things in a hospital or in a care setting that a smart medical student would be able to do. If you could get an AI that could do what a smart medical student could do here and what could do there. And so it sort of raises the question of, well, what are we going to train our smart medical students to do now? So what do, panelists, what do you think about how this changes medical education, and what are sort of the entry access points now that young doctors or nurses or other clinicians have when it comes to the healthcare space, if AI is going to be taking on some of their workload?
So I can say that.
Yeah, go ahead, Casey.
So one of the faculty members in our department and I are putting together, we have these things in our curriculum called selectives. So we're putting together a selective on AI and its use in healthcare. CT and Matt, you can expect some invitations to contribute to that in the not very distant future. Now that you're asked on a panel, you have to say yes. But yeah, I think this is a really good point. I think medical education is not always the fastest moving area in terms of integrating new content into the core curriculum, but many medical schools, including our own, have these kind of selectives to layer on top of the core curriculum. And to my knowledge, that's where this information is currently being added to medical school curricula, but I could easily see with the growth of this as a topic that it sort of works its way more and more into the core curricula.
I'll jump in, and I would love Matt's insight into this as well. It's too late. I think this GPT tools are public, and so it's not up to a professor to say now you have permission to use this tool. I think our students are out there already using it, and what we have to do is adapt as teachers to being able to say it's part of the water, it's part of the environment, and how do you adapt to it? I'm aware of. As I understand it, as I was reading what college professors are doing with take-home exams in the era of GPT, is reaction number one is ban it from the classroom, and say, we're only going to do exams in class where I can watch you do your work and you have to put your laptops away, to now I think they're pivoting to saying, this is take home work, and I expect you to take your take home essay and give it to GPT, and I want to see that draft. And I want to see you edit and improve the draft based on what you've learned. You're now the executive editor for a journal, and I want to see both versions because that's where I'm going to see your thinking. And I think that's the same thing for medical students is we're going to need to give them all these new tools and then say, we're going to ask you to elevate your thinking because we expect the grunt work to be done for you and you need to, take it to the next level. And that's the kind of thinking that we have to stay ahead of. I think writ large, this is sort of healthcare in almost every other industry is that we can't go into a job and go, my job's going to be static for the next 30 years. Like when I started off in my career in 1995, I think now we have to say every 2 to 3 years, we have to reinvent our role. What are we going to do? The technology is different. The platform's different. The environment is different. Who do we see ourselves as? And it's the same thing for our students. Who do you see yourself as a student? Because, the ground underneath us is changing.
Matt, do you have thoughts?
I totally agree with CT, and I would just add that I feel like at every medical education conference or forum I've been to in the past 6 months, this topic is on the table. And so I think every medical school around the country is finding ways to address this in their own ways, and probably the AAMC, which governs, so to speak, medical schools is as well. So I think this is an emerging topic and everyone knows it's important. And I think schools are going to address it.
We have a question here about navigating individual states' healthcare policies when applying AI in your work. Is that something that becomes an issue? CT, I don't think, does UC Health have facilities in other states?
Yeah, we do. We have facilities in Wyoming and Nebraska.
Yes, that's right.
Not so much AI policy. State by state medical policy is a complete nightmare for us. During the pandemic, we had to make sure that when a patient dialed into a telehealth visit, if you're coming from Wyoming and your doctor's not licensed in Wyoming, sorry, you can't have this visit. We have patients driving across the border, parking in a 7-Eleven parking lot so that they can do their telehealth visit with us because so no in regards to AI, but yes, in terms of state regulation is a nightmare for us in general.
Okay, well, if there's any more questions that folks want to post in the chat, we can get those answered here real quickly, but I thought we could close out with I'd ask the panelists each the same question, which is there's a lot of, I think, fear around AI and how it's going to change healthcare and what it's going to mean to change healthcare. Does it mean you're going to see your doctor less and you're going to end up talking to a chatbot more? Does it mean that your insurance company is going to apply some AI system to determining when it pays for your care and when it doesn't? So just on the whole, and maybe there's some selection bias in our panel here, but I thought we could go through and see how optimistic you are about the potential for AI to improve healthcare versus the potential downsides. And Casey, why don't we start with you?
Yeah, so I guess I'd say I think I see an enormous amount of potential these types of technologies to improve healthcare, in particular to potentially improve our efficiencies with things that are sort of less direct patient contact. So, summarizing notes, for example, and these types of tasks where, we can imagine AI systems that might be able to take a conversation and really summarize that or distill it down to some key elements so that when your provider is with you, your provider is wholly focused on you. And I think like that ability to allow providers to convey the empathy that they feel towards their patients, I think is a real opportunity. And that, is something that kind of we may have lost a little bit along the way. So, and I think it could help us get it back. So I guess to me, I'd say I'm optimistic. I think these algorithms create paths to better care if carefully deployed. So I'll take the optimist perspective.
CT?
I'll say that I'm 3/4 optimistic and 1/4 pessimistic. The 1/4 pessimistic is we know that the large institutions, pharmaceutical companies, government regulators, insurance plans are also applying AI. And I think that's already showing up in terms of automatically denying things, because we can do that faster now. We can deny your request faster than we could before. And but I'm 3/4 optimistic that there are so many opportunities to help assist expert clinicians who are overburdened by reducing the burden. And we think there's a huge opportunity to go forward there.
And Matt?
Yeah, I would say cautiously optimistic, at least overall. My hope is that the attention that's being given towards fairness and unbiased AI really gathers even more momentum. It's far too easy in healthcare to look at outcomes overall, greatest good for the greatest number, and forget, or to put off till later. Well, why not have the chatbot in a language other than English? Let's make sure that the model is fair across all patient groups. We'll do that later. Let's just do it first and then get to bias and fairness later. And so my hope is that some of those questions move farther upstream so that we can address them proactively and maybe even reduce or eliminate some of the disparities we have in healthcare.
All right. Well, I think that takes us to the end of our time. So I want to say thank you again to the panelists. I really appreciate all of you. And it was another enlightening discussion and completely different than what we did just a few months ago. So it's kind of funny the way things evolve and how much there is to talk about with this subject. So I want to thank all of you and just appreciate your time. So Bob, I'll give it back to you.
Okay, well, thank you so much, John. You did a fabulous job of moderating this panel, and thank to our panelists as well. I first saw this panel assembled at the Colorado Sun event, the SunFest, a few months ago, and thought it would be a great thing to bring to more people. So thank you all for doing this again, and to a different crowd.